No.
Ma'am, we are
Yes.
in live, ma'am.
Okay. Very good evening to one and all of you, very dear CSOs members and many more, hopefully who have joined in from the Tamil Nadu Association. We all know that diabetes has become a very major health issue, and probably any amount of awareness, if we could generate, would be insufficient because it's become a mammoth problem. So the whole concept of this webinar is how do we go about preventing it? How do we stabilize it? Or how do we live with it so that we have at least done one thing towards addressing this raging issue of the hour? So I'd be very, very thankful to have the most eminent expert panel here around me. And I think I couldn't even have got it better at an all India level. We are truly lucky to have with us Dr. Ganesh Raman, who's the Chief of Glaucoma Services of the Arvind Eye Care Systems, Coimbatore, who's going to be joining us shortly. We are lucky to have with us Dr. Prabhu Shankar, who's a Senior Consultant Retina Services from the Shankara Eye Foundation, individual with great expertise, and I really look forward to learning a lot from his thoughts. We are lucky to have with us a senior and very eminent, a very essential feature of CSOS, Dr. Rajendra Prasad, who is a senior consultant at the KMCH Institute of Health Sciences and Research. We are lucky to have with us Dr. V.R. Sharvanan, who is the Chief of the Retina and Vitreous Services of the Arvind Eye Care Systems based at Coimbatore. And yes, I know I'm lucky to have with me Dr. Ashi Nayaka, who's a young, dynamic consultant, Vitreous Retina Services at the Eye Foundation Group of Hospitals. And I look forward to him being a buzz through these 1.5 hours. Moderating with me yet to join is Jayashree. Have you joined it? Jayashree might have some network issues, and if so...
Yes, ma'am, I've joined. I'm just keeping my video off as of now.
Yeah.
So I'll switch it on.
And moderating with me and being a very essential part of it all is our Secretary, CSOS, Dr. Jayashree Arun Prakash. And I'm sure she'll know how to steer this whole meeting very well and get the best from all of you. So without wasting time, we shall go on to our first master class, which is the topic is cataract surgery in diabetic patients, pre-op considerations and intraocular lens preferences, which is probably so quintessential for us anterior segment surgeon. And this is going to be addressed beautifully by Dr. Tamilarsi, who's a senior consultant, cataract and intraocular lens services at the Eye Foundation Group of Hospitals, Coimbatore. Again, a very efficient and versatile surgeon. On to you, Tamil. You could share this.
Yes, ma'am.
Yeah.
Thank you, ma'am, for this opportunity, and I thank CSOS. Are my slides visible, ma'am?
Yes.
India is considered the diabetic capital of the world, and it is estimated that up to 20% of cataract surgery are performed in diabetic patients. Considering this, as a cataract surgeon, we should know the key risk and risk mitigation practices when performing cataract surgery in these eyes for optimizing the results. Given the epidemiology and demographic trends of diabetes and cataract, we are likely to encounter patients with both comorbidities at an increasing frequency. So during pre-op evaluation, the need for thorough asepsis cannot be overemphasized. And we should do a thorough comprehensive ophthalmic examination, including refraction, and the best corrected visual acuity should be correlating with the grade of cataract. If not, do a thorough fundus examination and do OCT for looking into the macular status. And this acts as a documentation and helps in the follow-up if the patient develops a macular edema in the postoperative period. And a slit lamp biomicroscopy, look for the iris, especially neovascularization of the iris in case of advanced PDR and relative efferent pupillary defect. Also check for the maximum pupil dilatation, which could be achieved in that case. And FFA and ultrasound whenever indicated after consulting with the VR surgeon. The pre-op counseling is very essential in these eyes to manage the expectation, especially if they have associated DME or PDR. And also we should discuss the need for post-op intervention and treatments and the need for strict control of diabetes, and also ensure that the patient is able to come for the follow-up visits. There have always been questions about the optimum pre-op blood sugar control for patients with diabetes prior to cataract surgery and is yet to be determined. This report from the Royal College of Ophthalmologists states that diabetes patients should have their blood sugar control before surgery, but the decision to proceed or not should take into account of the clinical and the functional requirements of the patient and also the clinical judgment of the surgeon. These patients with cataract surgery are a high-risk population than healthy patient for cataract surgery. This is because of the potential that the risk that diabetic eye disease may progress as a direct result of cataract surgery. The risk factors being the advanced level of retinopathy and the presence of macular edema, the duration and the complexity of the cataract surgery, and uncontrolled blood sugar level. All these factors plays a role in advancing the pre-existing diabetic retinopathy and gives us suboptimal visual outcomes. The eyes with mild to moderate NPDR with normal macula, these eyes have best outcomes which are on par with their non-diabetic pairs. Diabetes as such does not predispose to complications like PCR or zonular dehiscence, but the effect of diabetes on the entire eye can result in problems. Ensure that we're not creating any even small epithelial defect. Because of the impact corneal innervation, patient could have recurrent epithelial erosion in the postoperative period. These cataracts are often called as gummy cataracts. Here I attempted to chop, but I ended up in an epinucleus bowl. So I used visco dissection to just lift the epinucleus bowl and then did quadrant emulsification. Also, the pupils can be poorly dilated, and as a surgeon, we should be prepared with pupil expansion devices to address this. The IOL choice in these patients is not different from a routine cataract surgery. If there is astigmatism, we can go in with the toric IOL. And if the patient wants a spectacle independence, we can go ahead with a trifocal IOL. And this patient opted with a trifocal IOL, and we did that. The patient did well in the postoperative period. The next is femtolaser-assisted cataract surgery and diabetes. We know that with femtolaser-assisted cataract surgery, we can place segments and softening patterns, which effectively decreases the phaco time and the cumulative dissipated energy. Here you can see even after completing the phaco emulsification, the CDE is very minimal, is 6.67. And hence less endothelial cell loss and less inflammation. But there are multiple studies which shows varied results in these eyes. Diabetic patients with pre-existing macular edema are at increased risk of either worsening of edema or recurrence of edema following cataract surgery, and always cross-consult with a VR colleague and coordinate with them regarding the timing of surgery and need for adjuvant treatment in these eyes. This is a patient who had a diabetic macular edema extensively treated with anti-VEGF, steroids, and laser focal, and she was lost to follow for about 9 months. And when she came after 9 months, she had a significant cataract. Her vision was just counting fingers, and the OCT showed a paramacular edema. So coexistent DME at the time of cataract surgery warrants a combined phacoemulsification and the treatment of DME. It could be either an anti-VEGF or an intravitreal steroid. Here the patient chose that it was treated with dexamethasone implant and ensured that the blood sugars are under control. And she underwent both eyes with a gap of around 3 weeks, and she did well. Postoperatively, we should ensure that we are going to follow up these patients very carefully to evaluate the macula for progression and along with metabolic control. So in these eyes, attempt to stabilize and resolve DME prior to cataract surgery and perioperative stabilization of the DME and postoperative close follow-up, all are these going to give great success in anatomic recovery and visual function. And we should differentiate diabetic macular edema from pseudophakic cystoid macular edema because the pathogenesis, treatment, the natural course and outcome is going to be different. We know that diabetic macular edema is always associated with other features of diabetes mellitus like hard exudates and microaneurysms, whereas pseudophakic cystoid macular edema, we are going to expect minimal diabetic retinopathy changes if the patient has, and no exudates. And OCT is an invaluable diagnostic tool in such cases, whereas in diabetic macular edema, we are going to see the edema in the ONL and the Henle's layer with hard exudates and foci with disruption of the photoreceptor layer. Whereas in pseudophakic cystoid macular edema, we are going to see macular edema along with SRF and the intact hyperreflective bands. Next, coming to cataract along with PDR. Severity of the cataract sometimes prevent adequate examination and treatment of the proliferative diabetic retinopathy. Here, the right eye had an early cataract, whereas the left eye had significant cataract, and the patient had an uncontrolled blood sugar level. So the right eye has been planned for panretinal photocoagulation, and the left eye phacoemulsification along with anti-VEGF and PRP in the early postoperative period. So as a cataract surgeon, what we do is good phaco, ensure that the cornea is clear, and refer the patient to the VR colleague at the early post-op. I have referred at 1 week, and 3 sittings of laser photocoagulation has been done, and the patient had a good visual outcome. In case of non-resolved vitreous hemorrhage, macular TRD, or a combined mechanism of RD, or any persistent macular edema not responding to any other form of treatment, along with cataract, we are going to plan a combined phaco-vitrectomy. A word of caution in these eyes, whenever the macula is involved, either because of a subhyaloid hemorrhage or a tractional component, here you can see that the left eye, the fixation is not obtained. So the optometrist has acquired this axis length value from the immersion ultrasound, and you can see that it is erroneous. It is falsely short axis length, and this reflects on the IOL per calculation. So as a cataract surgeon, we should be aware of this. And if the other eye is, the macula is normal, assuming the patient, both eye had a same refractive error, we can go ahead with the other eye axial length. And if you feel that the other eye is also involved and the macula is problematic, we can plan the IOL as in secondary stage. And coming to the problems associated with a combined surgery, we are going to have a poor red reflex. So I'm using a tryptophan blue for staining the anterior lens capsule, and the capsular excess is being done. And combining phaco-vitrectomy gives the advantage that it gives the early and rapid visual rehabilitation and avoids a second procedure. And here the patient had a poor corneal endothelium, so I'm using a dispersive viscoelastic which coats the corneal endothelium, and the stop and chop technique is being performed for nuclear fragmentation. And clearing the cataract also gives an additional advantage for the VR surgeon so that they better visualize the posterior segment, especially for membrane peeling, and they can address the vitreous base pathology more better, and ensure that you're suturing the wound so that the anterior chamber is maintained while performing the vitreoretinal surgery. And while forming the anterior chamber, in the end, do not overhydrate the wounds which can come into the visual axis and obscure their view. And I always prefer to put a viscoelastic before sending them to the VR surgeon. If you're performing a sequential surgery, already vitrectomy is done. While doing biometry, a word of caution, always choose the vitreous body state. If the silicone oil is put, choose the silicone oil mode, and this automatically adjusts for the change in the refractive index between the vitreous and silicone oil and gives us the accurate axial length for calculating the IOL power. We should understand that when a prior vitrectomy is done, these eye is anatomically different. Because of the loss of vitreous support, we can have an exaggerated AC depth. AC can be very deep. So I've just reduced the bottle height from the usual 79 to around 54 to 55 with a corresponding decrease in the aspiration flow rate so that I'm not facing a surge. And also while performing a hydrodissection, we should be careful that we are not doing a vigorous hydrodissection. Another thing which we have to keep in mind is that reverse pupillary block, otherwise called lens iris diaphragm retropulsion syndrome, where immediately on entering into the anterior chamber, we can have your anterior chamber to be excessively deep. To avoid this, always use a second instrument just to lift the iris so that the fluid goes both into the anterior chamber and the posterior chamber, and this excessive deepening of the anterior chamber could be averted. In such eyes, always ensure that your wound is not too long. If it is going to be too long, then instrumentation is going to be difficult. So make sure that the instrument clear corneal incision is adequately sized. And if this is a case where vitrectomy is done and also silicone oil has been removed, while performing cataract surgery in such eyes, always we can expect such a dense plaque. If you could get a dissection plane, it is well and good, we can remove it. This comes in toto, but if it is a thin fibrous plaque where you're not able to get this dissection plane, we can treat it in the postoperative period. And in eyes where the silicone oil is not removed, attempting this, if it opens a PC, and it is going to be a messy situation to handle because all the silicone oil is going to come into the anterior chamber. Another word of caution, cataract develops after vitrectomy, but it's usually of nuclear sclerotic cataract, and it develops and it takes months and years to develop. But here you can see that the vitrectomy has been done in July, and in first week of August, the patient has been planned for cataract surgery, and this is an intumescent cataract. So always do a slit lamp assessment thoroughly to check for PC status, and also do anterior segment OCT just to ensure that the PC integrity is there, and make sure that the scan line passes at the line of suspicion where you're expecting the PC rupture. This is a case where you can see in the slit lamp, even the compactness of the cortex is not there. You can see an empty space here with the corresponding PC dehiscence and outpoaching of the lens matter into the patella fossa. And there is a dose-dependent increase in the frequency of PCR with multiple intravitreal injection. And this patient has been treated with multiple intravitreal for CME retinitis. And you can see that the sealed PC tear and a concave appearance of the anterior lens capsule, even which is made in the slit lamp examination. So always this has to be kept in mind. And if it is a fresh PC tear, we have to wait for at least 4 to 6 weeks for the fibrous plaque to develop around the PC edges, if possible, to proceed before surgery. And when you're addressing such case, treat it as a PPC with PC dehiscence. Here the cataract is intumescent. So my aim is to aim for a rhexis, so that if at all a large PC dehiscence was there, I can place the lens in sulcus. And this was very soft cataract. So I didn't use my phaco probe. I just aspirated the cataract using IA. But in case if you have a formed nucleus, it is better to perform a hydrodelineation. And since there is lack of vitreous support, as soon as you take your phaco probe in, the PC tear can extend and the nucleus can drop. Here you can see that there is a focal PC dehiscence, and I didn't allow my AC to collapse, injected visco, and I placed 3-piece lens in sulcus with optic capture. And control of inflammation is really important in these eyes. And always give a combination of steroids along with NSAIDs. The green one is the usual routine of steroids, which I give for normal patient, a short taper of steroids. Whereas in eyes where there is an advanced PDR or macular edema, I ensure that there is a slow taper of steroids along with NSAIDs to control the inflammation and to decrease the chance of the diabetic macular edema or CME. The IOL choice, I think it will be discussed with the subsequent speakers, but the points to notice, always we prefer an hydrophobic acrylic because of the good biocompatibility. And I said earlier, mild to moderate NPDR with normal macula, there is no restriction to the IOL choice. We can proceed as usual. Whereas in PDR or advanced DME, avoid diffractive IOL. One thing, it is going to decrease the contrast sensitivity and the patient will not be satisfied. And sometimes it acts as a hindrance for further treatment of the retinopathy. And in any doubt, discuss with the VR surgeons while choosing the lens. Thank you.
That was a wonderful talk, Tamil. I think it just leaves hardly anything for discussion, but just for the sake of discussion, I'll take a question or two, but that was truly a brilliant talk. So, Dr. Sharmanan, who's there? Dr. Sharmanan is there? Dr. Jayashree?
Tamil, yeah, that was an excellent talk.
I was
very comprehensive. I have a couple of questions.
Actually, I thought I'll ask this question to you itself because I
yes, please.
Yes, Dr. Prabhu is there. Yeah, I just wanted to know what is that ideal time lag following an intravitreal injection and laser when you would think of performing a cataract surgery?
Madam, preferably a dry macula, madam, before we operate.
Yeah. Okay.
Based on OCT, madam.
Based on OCT, yes.
That should be the ideal way to go.
Yeah. Anything to add, Dr. Ashray? You have to unmute yourself.
So basically, as Prabhu sir told, dry macula sometimes take a lot of time. So we have to optimize the rehabilitation process. Sometimes if we think the cataract really contributes more for the vision loss, maybe we have to counsel the patient and do it simultaneously. But otherwise, in ideal scenario, we would like to have a dry macula. But in chronic macular edemas and diabetic macular edemas, if we are able to find a right thickness and relatively free macular edema, and if the cataract is contributing so much, we can also do it simultaneously.
Yes, Dr. Jayashree, you could take your question.
Yes, Tamil, in a couple of cases, I saw that when you went for the cataract surgery, the blood sugar was around 250, 260 and HbA1c 9. So what is your take on the blood sugar control for cataract? When do you think that you can go for cataract surgery, especially when we are combining cataract surgery with intravitreal steroids? What
No,
is it that
actually,
you feel we can do?
those pictures which I showed was the initial checkup value when we did the workup. If the blood sugar is high, we always do the HbA1c just to know whether this is the one-time value which is high or the patient has been chronically uncontrolled, have the chronic uncontrolled blood sugar. If it is high, we always ask for a diabetologist fitness, but the cutoff value what we follow is less than 200. A random blood sugar of less than 200.
And
Okay.
Amal had already addressed about the post-op medication, but I wanted a thought of our retina consultants here. Dr. George, would you want to change anything which the routine cataract surgeon does as far as the post-op medication is concerned? I know it's a very basic question.
No, actually, I would take that question because it's very important, because it's not like a routine cataract surgery. Here, now the trend is of not using much of steroids and the things. But then when you have a diabetic retinopathy, and especially in a subtle diabetic macular edema, the new concept is that there will be 100% worsening of that macular edema. So it is extremely important that these patients need to be treated. Like I do agree with what Prabhu said. You aim for a dry macula. Earlier days, the teaching was to get a dry macula before surgery. But now, even in subtle edema, we don't hesitate to, because we have anti-VEGF, and very recently the DEX implant, we treat them, and within 2 weeks of DEX implant, we take them up for cataract surgery, because the next 3 months would be taken care by the DEX implant itself, even if you don't have any topical steroids. That's a situation that we are looking at now. But it's a routine practice now. We combine it with anti-VEGF agents. Phaco with anti-VEGF agents is because 100% there is going to be a worsening of diabetic macular edema. And regarding the eye drops, if any of my patients are undergoing cataract surgery, 3 months before doing the surgery, start NSAIDs 3 times a day for next 3 months. There is no taper. And even after the surgery, no loteprednol, and usually we give a proper 1 month course of prednisolone acetate, and then that takes care of the macular edema. But there will be a confusion sometimes where you'll be confused whether it's a CME or it's a worsening of DME, and that actually a therapeutic trial is the only way to clear-cut take care of both the situations. These are my take on that.
Thank you. Thank you for all the wonderful inputs. We go on to our first interesting debate. And this is going to be taken on by Dr. Anusha Koshal Ram, who's a consultant at Ponnamal Doraisamy Eye Hospital and Retina Center. And she's going to tell us that in a diabetic, she's going to play it very safe, and monofocal is the IOL of choice. On to you, Dr. Anusha.
Thank you, ma'am.
Please stick to your time. Velmurugan,
Yeah.
keep a watch on the time.
Full screen.
Yes, ma'am. Sure, ma'am.
What happened?
Yeah, 1 minute. Just
Yeah.
Ma'am, open your presentation after you go to share screen, ma'am.
yeah.
Your presentation is already open, and then you go share screen. Yeah, good.
Yes, ma'am. Yes, ma'am.
Is it coming full screen, ma'am?
No, it's
No,
not.
ma'am. No.
Yeah, now is it full screen?
It's not full screen.
Not full screen, ma'am. It's loading.
Can you share it again?
Yes, ma'am. Full
It's fine.
screen.
Go ahead. On the list.
So, good evening to everyone. At the outset, I would like to thank Dr. Chitra ma'am for having given me this opportunity to speak on this platform. I would like to start my talk with the saying of this great physician, Dr. Howard Root, who said that ocular complications in diabetes are frequent, distressing, and destined to become one of the great challenging problems in future. So as ophthalmologists, it is our moral responsibility to not only treat the diabetic eye disease, but to treat the whole disease by proper referral. So I would be talking on monofocal intraocular lens as the preferred choice in diabetic patients for cataract surgery. We all know that every diabetic is a potential candidate for developing diabetic retinopathy at any point in future. So as a cataract surgeon, when the decision of taking intraocular lens for cataract surgery comes, I would undoubtedly choose a monofocal intraocular lens rather than a multifocal lens. We all know that there is aggravation of the diabetic retinopathy status following cataract surgery, irrespective of the level of retinopathy at baseline. According to ETDRS study, there has been 5-year progression of the proliferative diabetic retinopathy to PDR once the stage increases from mild to severe. A subgroup analysis has also shown the aggravation in the diabetic retinopathy status following cataract surgery. So now the question might come, why a monofocal is preferred? The answer is because diabetic patients, as Tamil Madam has told, they require frequent dilated retinal evaluation to detect whether diabetic retinopathy is present or not. And if present, the proper detection and treatment and management is very, very important. These patients might require multiple laser sittings if needed. They might also require multiple injections of anti-VEGF. Some cases like vitreous hemorrhage might progress to surgery also. So in these cases, the ease of performing all these procedures would be undoubtedly much, much better and easier if a monofocal implant is there instead of a multifocal implant. So now my colleague, Dr. Anand sir might ask, why not a multifocal implant? Because in multifocal lenses, because of the presence of the annular rings, the fundus evaluation might become very, very difficult, and the examination beyond the equator up to the ora serrata might be a challenge. Because of the presence of the annular concentric rings on the optic surface, the visualization during the laser delivery might also be very, very difficult. In multifocal lenses, a point focus of the image is not formed. So instead, multiple foci of images are formed on the observer side. So during the laser delivery, there might be scattering of the light, which might impair the delivery of effective laser to the posterior segment. Again, multifocal has been found to reduce contrast sensitivity, hence they are discouraged in diabetic patients undergoing cataracts. Various studies have been done which have shown that the contrast sensitivity has been reduced in mesopic conditions. This is one such study, Dilda et al., in which they have compared various multifocal lenses like Optivis, Rezoom, and Restore. And they have found that the contrast sensitivity was reduced in the multifocal lenses when compared to the monofocal IOLs. These are various studies done with the multifocal lenses like Yamuchi et al. And Jai et al., in which they have compared the monofocal implants and the multifocal implants and have found that the contrast sensitivity of the multifocal implant was significantly reduced as compared to the eyes with monofocal implants. Macular edema has also been found to aggravate after cataract surgery in diabetic patients, irrespective of the level of retinopathy at baseline. This is because of the increased production of the inflammatory factors and also the altered concentration of angiogenic factors and VEGF. In one such studies, they have measured the retinal thickness following the cataract surgery, and they have found that the retinal thickness has increased, and it was maximum at the second month following cataract surgery. Post-op cystoid macular edema is very, very common in diabetic eyes, and we are all aware of this entity, Irvin-Gass syndrome, which warrants early detection and treatment and management of this entity. So with the multifocal implant in situ, it would become very, very difficult to pick up subtle changes at the macula. Hence, they are discouraged in diabetics. So in a nutshell, I would vote for a monofocal implant in diabetics because issues like glare and halos are not...
Doctor, 1 minute more.
Yeah, contrast sensitivity is normal. Fundus evaluation can be easily done. Laser application, there is no scattering of light, and the view during retinal surgery is not compromised. So considering the huge amount of quantum of money which these patients would be spending on frequent visits to the ophthalmologist and anti-VEGF injections and multiple laser sittings, it would not be wise on our part to further burden them up with a high price tag of a multifocal lens. So my preferable monofocal lens in a case of diabetic patient would be a hydrophobic acrylic because they have got a low propensity to silicone oil and can be safely placed in diabetic patients. So my take-home message would be a good diabetic control and a good hyperlipidemic control also, and a clear, uneventful cataract surgery with minimum handling of iris, and a good CME prophylaxis with judicious use of non-steroidal anti-inflammatory drug, serial dilated fundus evaluation. So my choice of IOL for any level of retinopathy in diabetic patient would be undoubtedly a monofocal or a toric monofocal and not a multifocal lens. Thank you.
That was a wonderful presentation, Anusha, very crisp and actually nearly convinces us that that's the way to go. So we look forward to Dr. Anand,
Thank you,
who's
ma'am.
a senior retina refractive and cataract surgeon from Lotus Eye Hospital, and again, a very important figure in our CSOS society. Let us hear what this daring surgeon is going to say, why he would think of using an EDOF as against safe monofocal in a diabetic. On to you.
Yes. Madam, good evening. Thanks for the opportunity, and good evening to Dr. Jayashree also for this opportunity. I think Dr. Anusha was just telling that monofocals are better, and she was more talking about multifocals are not preferred. Yes, I agree with Anusha that multifocals are not a preferred choice at all, but I'm going to speak on EDOF, which is better than monofocals in diabetics. Multifocals is never a choice. Even 10 years back also, we would never prefer multifocals, but EDOF, why? Let me talk to you. Next slide. Next slide, Velu Murugan. No financial disclosures. I do just high volume EDOF lenses. If you look into the literature, there is no published data which gives us the usage of EDOF or trifocals and the comorbidities as of now. And whatever I debate or give my data, it's only on the facts of few experienced surgeons and my personal experience. Next slide, please. As Dr. Tamilarasi was telling, diabetes is on a rise. If you look into the incidence and prevalences in India or globally, there's a huge rise. At the same time, the usage of EDOF lenses for the last 4-5 years has been increased. And with the help of diabetic physicians, we are able to control the progression with very good glycemic control, control of hypertension, serum lipids, and modern day anti-VEGF. And most of the patients are able to get their OCT done on each and every visit. The concept of dry and the wet OCT is well known. Next slide, please. Next slide. Why we do not prefer presbyopic correcting IOLs in diabetic? Because multifocal, yes, we do not use trifocals less. Because these lenses, since they have diffractive rings, they might tend to reduce the contrast. Because of this diffractive rings, down the line, these patients may require PRP or vitrectomy that may hinder the VR surgeon's view. And healthy macula is always required if as to work well in trifocals or multifocals. Next slide. What are the other facts we should know? The visual acuity in diabetes is reduced because of diabetic macular edema. The most important concern here is the contrast sensitivity. Why multifocals were not preferred, or trifocals were not preferred? Because these lenses, since they're having the diffractive rings, they were trying to reduce the contrast, which might disturb the mesopic vision. But diabetic patients, if they are young, they tend to develop the cataract very early, and there is rapid development of the cataract in this sort of patients. Most of the times, whenever diabetic young patients comes to us for a cataract surgery, their complaint will be associated regarding to the vision, not much to the contrast. If at all, if they complain some clues regarding the contrast sensitivity, we can document their contrast and we can choose IOL of the choice, whether it's monofocal or EDOF lenses. Next slide, please. So these are all the things which Dr. Tamilarasi has told, and we all know intraoperatively to help out the retina surgeon in future, we make a good rexis. Now we have femto, we can go make rexis until 6 mm, do a good PC polish, keep IOL in the bag, and modern day cataract surgery is always a personalized approach. Next slide. So when these sort of diabetic patients, when they come with a cataract at a very early age and rapid progression, why these patients should not be given a benefit of EDOF lenses by which they will enjoy the EDOF benefits. The next slide, please. What and all benefits we have? See, any EDOF, we know that is always superior in its distant vision. It gives very good intermediate vision. The depth of focus is very good. With almost binocular implantations, their functional range is very good. Patients are between 45 to 60. During their productive age group, they can always get benefited. They can be of mild or moderate NPDR with dry maculas. They need to enjoy all these benefits. Next slide. If we understand the science behind the EDOF, as I told you, the diffractive rings of the multifocals or the trifocals can bring about the reduction in the contrast, but EDOF concept is entirely different. If you look into any of the EDOFs, they are built on three principles. There is a modulation of asphericity, there is achromatization of these lenses, and based on the Crawford law, it is built upon pinhole effect. If you, next slide, please. If you go into the classification, these EDOF lenses either we classify into pure or a hybrid lenses. These Technis lenses from AMO or magnification from the K group, they work on a concept called as sphericity modulation. So they literally work out the contrast because of well-maintained spherical operations. The contrast is not so much disturbed. And this OcuFocus, which works on the Crawford effects, it also doesn't affect the contrast very much. If you go into the hybrid, such as Synergy, they also have an inbuilt achromatization, means they have a technology where these violet rays are blocked and blue rays are made to focus onto the retina. The range between the bent red, the larger wavelength and the shorter wavelength is very small. The range of focus is very, very thin. The chromatic aberrations are maintained very much. So the contrast
Doctor,
is
1 minute more.
very well in this sort of patients. So if we understand, next slide, please. If we understand this concept of EDOF, why can't, next slide, please. And added to this, the safety and the efficacy of all the EDOF lenses, whether it's increased range of focus or enhanced depth of focus in form of VVT lenses, which comes in category of non-refractive, gives very good distant and the intermediate vision, mild NPDR, normal NPDR, dry macular status, it serves a very better purpose. Next slide. And if you compare the dysphotopsic phenomena of these lenses with any diffractive lenses such as trifocal or multifocal lenses, it literally has got very minimal amount of dysphotopsic phenomenon. Next slide. And in terms of vision, even the scale group magnification lenses, they give excellent distant vision and the intermediate visions. Next slide. So I would like to conclude, since these doesn't have rings, since these pure hybrid lenses, they work on aspheric modulation and chromatization, they do not disturb or bring about the dysphotopsic phenomenon. Any young diabetic dry macular patients, they do respond very well with EDOF lenses. And we need to understand that. I think any VVT or ION surgeon will accept that these lenses, they forgive with its landing zone and with its decentration also. Next slide. So EDOF lenses are the better choices for diabetic patients. Thank you. Next slide. Next slide. Thank you.
Thank you. Thank you very much, Dr. Anant and Anusha. And both of you did a very great job that at the end of each of your talks, we felt that is the way to go. So that's where we stand, somewhere in between. So I have a question. Dr. Rajendra Prasad, are you there?
Yes, ma'am.
Yeah. So do you believe that we should do an OCT in all diabetic patients, or would we do OCT only for those premium patients, or when we are actually suspecting a maculopathy? What are your thoughts on that?
My things will be, if you find that visual deterioration is not comparable with the lens changes, then definitely an OCT is indicated. Whether you are visibly able to see a macular problem or not, do a OCT always. When there is the lens changes is not as good, it is unable to explain the visual loss. Number one. And I have a question to Dr. Anant also. Sir, the EDOF lenses, they are specifically brought in for presbyopic patients, not exactly for diabetic population. There is not much of a literature in diabetic population and their complications or their usefulness when there is a laser delivery, or is there any?
Yes, sir. As I told you, there is no publications as such. These comes under the range of presbyopic correcting IOLs. They do very good for the intermediate vision and the functional near vision. Since they do lack these pure hybrid lenses, since they lack these diffractive rings, their contrast is better when compared to the trifocals and not so significantly lower when compared to the monofocals. That is why if you look into the science of IHANS lens or VVT lens, they work on the wavefront technology, and whereas the hybrid EDOF lenses, they work on the principle of called as achromatization, where they are able to have a good control of these chromatic aberrations.
Dr. Jayashree, would you have a question to take? Dr. Jayashree? What would be the, like if it's a quiescent PDR with a dry macula, Dr. George or Dr. Ashay, I think Ashay is an expert man. Would you suggest that we could do a trifocal or would you think of an EDOF? We are not talking of monofocals at this point. You have to unmute yourself.
So sorry. So actually, I endorse Dr. Anand's views here. We really have a paucity of literature. One of the studies by Tuminen et al. Published in 2020 in Graphes Ophthalmology, they actually compared all these multifocal lenses. The main problem with multifocal lenses, as told by Anand sir also, it cuts the light. So earlier the contrast was reduced by more than 20%. Now these newer lenses, especially EDOF and all, they have in the range of 10 to 12%. So this is again not validated clinically, but otherwise there are two conditions where are absolutely contraindicated, where such as retinitis pigmentosa and Stargardt's. Others like ARM, the diabetic macular edema are all relative contraindications. When patient has a bad visual outcome and then you have a multifocal IOL, it becomes a very hard task to manage it in the clinic, to explain them that the deterioration is not because of your IOL. So I would really take a minute and 10 minutes or 15 minutes to explain the advantages. And if the patient, like we have a lot of patients who have got multifocal IOLs and later developed after 2 years, 3 years, developed with macular edema or vitrectomy, they're all doing fine. We have, I'm sure Sarvanan sir, Tenarasan here, Coastal Ram sir have all operated vitrectomies and treated lasers in multifocal lenses. We really don't have a problem. But to do it in a primary setting, it takes a little bit of deeper counseling. As of now, there is no literature, but I don't think that in the coming years we can prevent, or it is not ethical to prevent patients, as an answer told, to give the benefit of all these lenses.
Dr. Jayashree, are you there? I think she has some network issues.
Yes, ma'am. Yes, ma'am.
In this debate, cataract debate, do you have anything to ask?
Yes. First of all, excellent presentation by both the speakers. I would like to ask both of you that this, what you have spoken on, Anusha, on primarily you want monofocal lenses, and Dr. Anand that you want to go for EDOF. Is this for all diabetic patients, or will you want to go take this approach only for those patients who have some form of diabetic retinopathy? So as our diabetic population is increasing, we have a lot of those patients who are coming just with diabetes, as of now not developed diabetic retinopathy. So what would your stand be on that? Would you go for trifocals in those patients?
I would like to play safe, and in case of patients having mild diabetic retinopathy, I would choose only monofocal lenses, irrespective of the level of retinopathy, because they might progress to moderate or severe at any point of time. So, but only if the patient is very much willing to go for a multifocal lens or an EDOF lens after proper counseling, I would like to take. But my first choice would be a monofocal.
Dr. Anand?
Doing wide field fundus photography and comparing after wide field fundus photography and comparison between the EDOF lenses and monofocal, you would be able to say like how the outcome is. Because since the EDOF lenses, they produce a longitudinally extended focal point. So it might cause some problem in laser sittings and all, I feel. So my choice would be a monofocal.
See, as I discussed in my presentation, the problem with any presbyopic correcting IOLs is all about the visibility to the retina surgeon, and it's all about the reduced visual function in terms of contrast. If trifocal or multifocals, because of its structure, if it is reducing it down, that is overcome by these EDOF lenses. As Ashraya told, there are few patients where 5-6 years back we might have operated, now they have macular edema, still they may be doing good. Reduced vision with altered contrast will become an issue. But majority of the times, the documented contrast sensitivity, either because of the vascular damage or because of the ganglion cell loss, is very, very minimal. And with diabetic patients help, you are still able to control their diabetes well, educate them well, and there are so many biosimilars implants which go inside. So diabetic macular edema, retina guys, take care. So I think when compared to trifocals, EDOFs are best in the diabetic patients. Let them at least enjoy their intermediate and near vision.
Dr. George, I have this final question before we move on. Do you actually believe that multifocal is causing a disturbance during treatment, that is during laser or doing a vitrectomy?
Yeah, firstly, you are mentioning about PDR. If the patient has a proliferative diabetic retinopathy, maybe Anand and they are mentioning about normal diabetics or with mild retinopathy. When you have a severe retinopathy as proliferative, high risk proliferative, you need to, that patient could go blind, whether you have a multifocal or VVT or whatever. So I do not concentrate on that. That patient would require a vitrectomy, silicone oil. You are looking at much more when you have a patient with high risk proliferative. So to your question, I do not counsel that patient. I mean, for any high-end
visibility during the surgical procedure.
So that is the first question which you discussed. The second thing to which regarding, I have operated on these multifocal IOLs and vitrectomy. Yeah, I mean, I do not see it's not an inoperable or any kind of situations. You can any experienced surgeon can manage in a multifocal kind of situation. But more importantly, the patients, as contrast and other problems, the patients will not have much of a benefit of putting that lens there. Actually, that is the main issue there. So rather than the laser, still we can do vitrectomy, still we can do, but then yes, it will cause some aberration, especially it is doing the peripheral part of the vitrectomy and all these things. It will cause some problem, but still manageable.
Thank you. We go on to our next masterclass. The first one was really, truly amazing. And we have a very versatile, dynamic person doing this. It's Dr. Satyan Parthasarathy, who's the director of the Satyan Eye Care Hospital and Coimbatore Glaucoma Foundation. And he is going to tell us something very, very important. How do we improve outcomes in neovascular glaucoma? On to you, Dr. Satyan.
Thank you, madam. Hope you can see my slides. Yeah. So this is one of the very difficult glaucomas to manage in our outpatient department. And it is one of the most intractable secondary glaucomas to treat. So earlier days, at least when we were starting our glaucoma practice, once we see the neovascular glaucoma, that's the end of the day, where we can possibly just give some drugs and then manage. But nowadays it is not so. We can definitely give them a good vision and we can definitely save their vision. That is as soon as you identify the cause. So that's the take home, very important take home. So if you really look at the hospital-based studies, the proportion of eyes with the NVG among the secondary glaucomas is between 9 to 17%. Though the prevalence looks pretty small in otherwise the general population. It is otherwise called as a rubeotic glaucoma. It could be called as a hemorrhagic or thrombotic glaucoma. That is all commonly called as. Just go back to the history. In 1906, courts described the new vessels in the CRVO condition. The neovascular glaucoma as a term is coined by Weiss et al. And the Walton et al. Has described the neovascularization of the iris first. So if you really look at the cause, 97% of the time, the retinal ischemia is the main cause, and only 3% becomes the inflammatory reasons. You can see in this chart, the retinal hypoxia and the ischemia, like there is a lot of release of the VEGF factors and also the other factors like IGF-1 and 2, the fibroblast growth factor and other factors, which causes the increase in the vascular permeability, the endothelial cell mitosis, leukocyte adhesion to the endothelial cells. What this causes, this group of cause is it causes the leaky vessels, there's a new vessel formation, and also the blood retinal barrier breakdown, which will ultimately cause the new vessel formation. And also the IGF part of it promotes the new vessel growth and the fibroblast proliferation. So in NVG, what you really see is the neovascular neovascularization and as well as the fibrovascular membrane. So there is an open angle glaucoma stage and there is an angle closure glaucoma stage. When this fibrovascular membrane becomes contracted, fibrovascular membrane causes the PAS and causes the angle closure disease. So there are four typical stages: the pre-rubeotic, rubeotic, open angle stage, and the angle closure glaucoma stage. We all know that one of the common causes for the NBG is the diabetic retinopathy, and the second commonest cause is undoubtedly the CRVO and the BRVO, and of course other causes you can see the ocular ischemic syndrome, tumors, chronic inflammations, and other radiation retinopathy. But most common is CRVO, diabetic retinopathy, and the BRVO. So you can see the NVD, that is the neovascularization of the disc and the neovascularization of the retina elsewhere. So what are the things that we should really look for? You can see this is a CRVO, but what is that point as? The arrow marks which you really need to look at is these white blocks. Once you see these white blocks, that is the hypoxic areas. This is basically for all the students or the other newcomers into this. So please look into this kind of areas. That is one thing. And the second thing is you can see in this video. So you can see the ectropia nuvae. Once the moment you put in the slit lamp, you can see that iris, the pupillary margin is not the same like the normal ones. So I'll just go through this. What are the other things? So 1 second. Okay. So there are, you have to look at the ectropia nuvae. The moment you see the ectropia nuvae, you should understand the patient has already gone in for an angle closure stage. That's a very typical, the thing that you should really know that. Then you see the blood vessels here. This is the neovascularization, just starting up to the colorate. Then it is just crossing the color, that is stage 2. Then beyond the colorate up to the angle, and then enters into the angle. So there are the 4 stages. So I told you, moment you see the ectropia nuvae, that is the stage where it is angle closure stage. You can see the blood vessel here. There is a monolayer, endothelial layer with the RBCs inside. So the layers are very thinned out. There's only one single layer. So what happens is even the patient sneezes, then it opens up, causing hyphemas. So what you really see in the angle, you can see there, it is not the brown color pigmentation there. It is basically much more reddish in color. You have to put it in the high mag, use a SLT lens to see this. You can use your gonial lenses also, but SLT lens gives you a much clearer view for you to look at the neovascularization of the angle. Always look at it. Sometimes you might miss the iris vessels, but moment you put in the gonioscopy, then you can easily understand that the neovascularization of the angle is seen. So then what else you will look for? You have to look at the blood mixed aqueous, and you see here, there's a fresh blood here, and then you see the bottom area that is either a khaki colored or it is a old clotted blood. The moment you see the fresh blood, that indicates the patient is still having an active disease. So this is very typical of understanding this. So once you see that there is active disease, then your treatment has to be augmented. And you see this in this patient, this vessel is a ghost vessel. This has already been treated. You see this iris pattern is altered. This is a ghost vessel. There is no activity. You can see the iris is also, it's a completely ironed out, flattened iris. And you see the pupillary margin. There is no ectropia anywhere. There's just a fibrovascular membrane. It is just completely ironed out with atrophic pupillary margin. With that, you can see the patient is having a corneal edema. When the patient, if we are given steroids in this patient with multiple bullet happening around, you should be watchful. These patients might develop a corneal ulcers. So this is one of the things that you should be careful about when you see the corneal ulcer. You can go for lasers, but we'll just come to that little later. So what are all the things that you should concentrate? The investigations, of course, you have to see all kind of investigations possible, but it is not only for ocular examination you need to do the multi-system organ disease basically. So you have to look at other systems, what are the things happening in the system. So the management, primary cause you have to focus, that is the retinal ischemia, possibly by the CRVO, BRVO, or diabetic retinopathy, or other possible causes. The secondary problem also you must concentrate the intraocular pressure, inflammation, cataract, and the vitreous hemorrhage. This again you will have to concentrate on. So two basic items that you have to concentrate. So basically treat the cause. One of the master drugs we have is the anti-VEGFs. In the anti-VEGF, one of the best acting anti-VEGF in this is the aflibercept, otherwise called as Eylea. The simple reason is it acts on all the three VEGF factors. That is PIGF. Then you have the VEGF A and B. That is one of the most potent than the bevacizumab. So it depends upon the cost factors and other things for the patient. But in ideal conditions, possibly these retina guys can, throw up more light on this. So Eylea is one of the common things. So lasers, of course, when you have the CRVO, two types, the non-ischemic and the ischemic. When you have the non-ischemic CRVO, always go for the peripheral PRP first, then later SOS, go for the anti-VEGF. When you have an ischemic CRVO, go with the anti-VEGF first, reduce the edema and everything, and then you can go for the PRP. So management options, of course, N. Satyan and the Talashruti is going to talk on multiple things. So basically, all anti-glaucoma medications like timolol, brimonidine, dorzolamide, all these things can be used. A relative contraindication might be the prostaglandins and the pilocarpine. It may not really work as good as other drugs. Possibly it might induce a little bit more inflammation. So, and the anti-inflammatory drugs, especially the steroids, is a definite choice. Though some people say that when you have a glaucoma, how can you use steroids? But there is an inflammatory response which is happening. So anti-inflammatory is a must, along with the homemade or atropine. Of course, the lasers, PRP, I have already mentioned. You have the micropulse. When you have the very high IOP, you don't want to take up the patients directly for the surgery. You can go the micropulse or the diode. When multiple treatments are failed, you can go with the diode lasers. Surgical option, I think, and Satyan is going to debate on whether trab or tubes, so they can concentrate on that. So the future therapeutic options, the pigment epithelium-derived growth factors, or
Okay,
the
1 minute more.
Yeah, I'm just done with this slide actually. So the Eylea, the anti-VEGFs are one of the mainstays. So give it at the earliest possible and do the peripheral PRP and non-ischemic CRVO. Treat the intraocular pressures. So definitely we can give the patients a much better. Even one of my patients, I just wanted to share as a last one. The patient came with the PL. I said nothing can be done. The IOP was about 50. Moment we gave the anti-VEGF again, he came back and we did the trab. Then I did the IOL. I'm talking about this all had happened in a period of 6 months' time. So the patient, the final visual outcome is about 624. From PL to 624, where I thought nothing can be done. So all of you can definitely give them a good, reasonable vision. So don't just leave out the NVG the moment you see that. Thank you so much.
Thank you so much, Dr. Satyan, for giving us a very cohesive picture. Instead of taking questions with your talk alone, let's complete the two debates and then we could have the questions, and that would help majorly. So we have the debate with Dr. Talashruti, who's our young consultant cataract and glaucoma services at the Eye Foundation from Group of Hospital Coimbatore. And she's going to tell us that in neovascular glaucoma, TRAB is my way go-to procedure. And contesting her is going to be Dr. Satyan, who's the medical director of the Eye Trust Hospital, Coimbatore, is also a past president IMA, and he is going to fight it out and say that JDD is the best bet. So on to you, Dr. Talashruti. Unmute yourself.
Yes, ma'am. Thank you, ma'am. Thank you for this opportunity. Ma'am, is it visible?
Yes.
Good evening, everyone. Today, the topic given to me is in NVGs in diabetics. Trabeculectomy is my go-to procedure. We already know that NVG is a very aggressive disease, and 33% of NVGs are due to diabetic retinopathy, and the incidence is quite significant. NVG in PD are about 21%, and rubeosis iritis in PD are about 65%. Diabetic with NVG in one eye, there is a high risk of NVG in the other eye also. Once we diagnose a case of NVG, it is important to medically manage not just the IOP but also the inflammation by giving steroids and cycloplegics. Adequate PRP and anti-VEGF as an adjunct is required to reduce the ischemia and also the neovascularization drive. Once the medical management fails and the IOP is still refractory and there are progressive disc changes noted, I would always prefer TRAB as the initial surgical option. Yes, TRAB is definitely a challenge in a case of a neovascular glaucoma, but still there are multiple reasons, and also considering the safety and long-term outcome, we can definitely consider TRAB as a primary procedure. I would also agree that in case of persistent and florid NVI and silicone oil filled eyes, TRAB might not be the best choice because there is a very high risk of failure. The success of trabeculectomy in NVG can be improved by the use of antimetabolites like mitomycin C and 5-fluorouracil and a good adequate PRP to reduce the neovascularization of the iris, and a prior ARC, and an intravitreal anti-VEGF will act like a very good adjunct to prevent intraoperative hyphema and also reduces the intraocular pressure. And vitrectomy can be done when there is vitreous hemorrhage. Once the trabeculectomy is done, even in post-op, we can titrate the IOP by placing releasable sutures and removing them, and assessing the bleb at every visit. And we can always give an additional 5-fluorouracil injections. And even after all this, if the TRAB fails, we still have the option of a bleb needling to try and salvage our TRAB before we think, say that the trabeculectomy has failed in our hands. There are many studies which show that with the adequate posterior segment treatment, the outcomes of TRAB and GDD offer similar success in case of NVG. And Rani et al. Showed that the eyes with NVG and visual acuity better than 20 by 20/100 at presentation had similar success rates in the outcomes of trabeculectomy in Indian eyes compared with the valves in the UK cohort. There are many studies which showed that if we combine an anti-VEGF injection with a trabeculectomy, the results are similar to that of tubes, or in some cases, even the effective treatment had less complications and a higher success ratio compared to tubes. Shan et al. Reported similar success rate for trabeculectomy with MMC and AGV over a period of 2 years. So now I would like to also tell why I am against tubes as a primary procedure. One thing that we have to keep in mind is that if we do a tube, like in case of an RD, which occupies so much space, subconjunctival space, that there's really no real estate left. Once the tube fails, with great difficulty, another tube can be performed. With a good trabeculectomy, even if after a few months or a year when it fails, we have enough space.
1 minute more, doctor.
To try at least 2 more tubes before we and save the visual potential. Also, we have to consider the cost factor, where in a place like India, many patients might not agree initially to a tube, whereas at least we can salvage the vision by doing a trap for the patient and later on follow it up, instead of losing the patients to follow up. And also, in a recent cost analysis, it has been indicated that the cumulative expense associated with tube shunt surgery was significantly greater than TRAB with MMC in the 5-year follow-up in the TVT study. We should also remember the complications of tubes like corneal decompensation, long-term hypertensive phases, which need to be kept in mind. And also, I would like to state that we have a 20-year follow-up study for a TRAB, which shows that there is 60% success with no topical medication and approximately 90% success with additional topical medications. So trabeculectomy surgery is a long-term solution for IOP control. Can this study be matched with a TVT study where we have only a 5-year follow-up for the tubes? And yes, this study does say that there's a higher success rate compared to a TRAB, but what about the long-term outcomes of the tubes? Who is going to manage the long-term complications in case of if the primary tube fails? And there are a few concerns in this study also. It shows that the failure rate of TRAB is slightly higher, but we do not know if the safe surgery technique has been followed by all the surgeons. And also the bleb leaks and hypotony noted are higher, whereas the mitomycin C concentration used in all the patients in the study is almost 0.4 milligram per ml for 4 minutes. Could this also be a cause? Is still a question. But this study does show that early IOP control and medication favored TRAB over tube, and there was no significant differences between the two procedures. For IOP after 3 months, medication after 2 years, vision loss and rates of late post-op complications and serious complications. So I would like to conclude by saying that with the well adequately done PRP and good medically managed IOP, a case of NVG, we should always prefer a TRAB first, considering the cost factor, the fact that we can save the superior subconjunctival space for further surgeries, and also that we have proven studies which show that we can TRAB is an option for long-term IOP control. Instead of blindly doing a tube first, I would first do a TRAB, and if it fails, definitely there is an option of a tube or a cyclodiode depending upon the visual potential. Thank you, and I would like to thank Chitra ma'am and Dr. Muralidhar sir for guiding me.
Thank you, Saraswati. That was a very well discussed debate. So let's hear from Dr. Satyan. Satyan.
Yes, madam. I'm here. Yes.
Sir, can I share the presentation?
I have already done it. Is my slides visible?
Yes.
Sir, it's white screen. It's white screen, sir.
White screen, huh?
Yes, Satyan, let him.
Yeah.
Velmurugan, you present?
Yes, ma'am.
Sharing, Satyan.
Stop sharing, sir.
Yeah. Some crash. You can share now.
Sir, it's visible, sir?
Yes.
Well. Start, Satyan.
Thank you, madam, for having me part of a debate. So I'm here to talk about glaucoma drainage devices in NVG management. Next slide, please. So as you know, as P. Satyan said, there are 4 stages, but primarily 3 stages of pre-glaucoma, open angle and angle closure. And only when you understand and clinically differentiate these stages, you can manage them appropriately. So next. So as Shruti said, there is a cost difference between TRAB and glaucoma drainage devices, which was exhibited in TVT study. But TVT study, next. TVT study didn't include NVG. It was an exclusion criteria, but they didn't study NVG in case of a tube versus trab study. So all those cost doesn't work in case of an NVG, which is a refractive secondary form of glaucoma, where you have to give a best shot, and it should be more effective one rather than a multiple procedure one. Next, please. So as I said, NVG was an exclusion criteria in tube versus trab TVT study, and so they didn't. That cost difference between a trab and a primary tube doesn't hold good for NVG. Next. So as you said, at the stage of rubiosis, secondary open angle glaucoma and secondary angle closure glaucoma. Just press once, please. So in case of secondary open glaucoma, where there is NVI, NVA, and still the angle is open, you can better do a trab. That stage is a better stage to manage a neovascular glaucoma, and identifying that stage of a neovascular glaucoma is very challenging, and you have to be very alert in identifying the open angle glaucoma stage. Whereas next, please press again. Whereas in case of an angle closure, angle closure stage where there is a complete 360-degree PAS formation, where doing a trab at that stage is very always it fails, and it doesn't have a good outcome. So there was a study which said long-term results of an early trabeculectomy in case of with mitomycin in case of neovascular glaucoma with hazy ocular media, and they had a significant success rate over a period of time if it is done early. Next. Next. So if the media is very clear, then you can reduce ischemia and reduce the release of VEGF by the way of pan-retinal photocoagulation or intravitreal anti-VEGF and all those things. And if the visual prognosis is good, then you can try any trab or a tube. Or if the visual prognosis is bad, then as she said, a cyclodistrict procedure. That is the last stage of management, where which is we generally consider that as a painful blind eye, and we can do a cyclophotocoagulation. But the debate is about what we do when the visual prognosis, as Dr. Satindra said, when even if patient has PL positive, you have to give a best shot, and what you are going to do at that point of time, it depends on whether the angle is open or closed. Next. So there are a lot of prognostic factors for trab in case of trab with mitomycin in neovascular glaucoma, and these prognostic factors plays a major role in surgical failure. Those factors are younger age group, post-vitrectomy, unremoved proliferative membrane, active inflammation, unrepaired tractional retinal detachment. A lot of prognostic factors which will help you in determining whether the trab will work in these patients. And when you find these prognostic factors, tube is the choice. Next. So my thoughts about favor in favor of glaucoma drainage devices are younger patients. When you have at least a hand movement of vision on maximum medical therapy and failed a trab, or you have attempted a trab before, instead of doing needling, 5 FU injection and all those things, you can directly go ahead with a tube. An IOP of more than 30, despite with or without post-trab, post-vitrectomy, and active inflammation, where there is a ciliary body hypoperfusion, and which is indirectly indicated by increased aqueous flare. And these patients, when you find out prior to surgery, and these patients have a very high risk of post-operative hypertony, and especially in case of a post-trabeculectomy rather than a post-glaucoma drainage devices, because in case of a trab, you have exposed the antechamber significantly, and there is a sudden drop in collapse of antechamber, whereas in case of a tube, you make a small port and insert a tube, and you have a controlled decompression of the antechamber. And if you have a fluoride NVI, you can argue me by saying that I can inject an anti-VEGF, wait for 3 to 4 weeks, and then do a trap. But even when you have
Doctor, 1 minute more.
Even when you have a fluorid NVI, the risk of severe hyphema is much lesser in case of a drainage devices compared to a trap. And when you have a 360-degree PAS, a tube is much better, and you can place them in sulcus or in pars plana when compared to a trap. Next. So comparing surgical outcomes of neovascular glaucoma between tube and trabeculectomy, they compared Barwell with trap, and Barwell did very well and reduced the intraocular pressure less than 70 in most of the cases compared to a trap patients who had trap. Next. So there is also a study about comparison between Ahmed valve and trabeculectomy, and they studied 40 eyes of 39 patients and over a period of 31 and 25 months respectively. And even though there is not much of a difference between tube and trap, but tube performed much better by the end of 1 year. The success rate was 70% and around 65% at the end of 2 years, whereas trap was 60 and 55% respectively. Next. So ideally, a valved implant, as NVG carries high risk of post-op. So non-valved implants are not a good choice for NVG. So a valved implant is much more important. Next. Adequate intracameral tube length, because the fibrin, if you keep the tube short, then the fibrin membrane might close the orifice and can cause blockage of tube. Next. Keep pressing. Ideally in ciliary sulcus or in pars plana. Next. Tube should be placed at least 1.5 millimeter in scalenal tunnel, because there is a risk of erosion, especially in patients with undergoing tube in case of NVG. And along with anti-VEGF, along with cataract surgery is much better if the IOP can be managed. Next. Finally, decision is based on the stage of neovascular glaucoma. If it is an angle closure stage, I would prefer a tube rather than a trap. Procedure is based on individual skill set, and if you are good in doing a trap in even a challenging situation, yes, trap is accepted. But even if the condition is very bad, then tube plays a significant role in reducing the risk of complication post-operatively. Whatever may be the procedure, the outcome is limited, and you have to choose wisely, and should be very careful about post-op complication, because risk of hyphema, risk of post-op hypertonia is much higher in trap compared to tube. Even though the outcome is not much, there is not much of a difference. Tube is slightly has an edge over the trap. Next. Thank you.
Thanks, Dr. Satyan. You also spoke very eloquently, and I think shortage of time, so I think I'll just jump to the questions. Dr. Ganesh Raman, are you there?
Yes, madam. Good evening.
Yeah, good evening. Now, going straight into the surgical thought process of neovascular glaucoma, if the tube is in the inferior location and it has failed, would you consider a superior trabeculectomy?
Thank you, madam. Thank you for having me as an expert in this meeting. Yes, definitely. I mean, you can give it a shot, because based on, even if you have a little bit of PAS, you can still get away with it. There's no harm in doing a superior trap, especially if the superior trap is not been attempted for whatever reason. But if you have a scarring there, then you have to have a plan B. But yes, conjunctiva is not touched, you could give a superior trap.
So how would you choose? We have these 3 tubes in the Indian scenario. So when you're going to do an NVG, what would be your thought process? Which would you choose and why?
Now, when we treat NVG, we have to understand you don't need very low target pressures. You just have to bring the intraocular pressure to the level of the other eye, because most of these are usually asymmetrical, and you just have to bring it to the other eye. And it depends on what all the medication the patient has been putting into his eye. Now, if the conjunctiva is really badly damaged, then you may have to plan for a low profile implant. So you may not have conjunctiva sufficient to accommodate, let's say, a AGV. For that, you have the alternative of, let's say, a ACP or a RD implant. So that's one issue which you can think of. And now we have the advantage of using the ripcord sutures. Now these ripcord sutures have the advantage of not causing so drastic hypotony, which used to happen previously. So we have all these advantages with us. So based on that, we decide. Now, if there's a previous vitrectomy has been done, then you have very less space to accommodate a RD. So you can plan for either AGV or a ACP. But vitrectomy has not been done. Conjunctiva is good, and you could accommodate a RD in these eyes. If you want to plan for an RD because of cost issues, you can even cut the wings of the RD and use the device like that.
Because Satyan is another big glaucoma person here, I'll take this question with Satyan. In a silicone oil-induced glaucoma, where the silicone oil has been removed and NVG has also regressed, in that situation, would you consider a MIGS procedure?
Straight away, no from my side.
No problem.
No mix. No. I said no mix for NVG because though what we see in the gonioscopy, we may not really see the vessels, new vessels. But even otherwise, all these vessels are very friable vessels. The moment you put in there, it will keep on bleeding all the time. And it is going to be a mess which you're going to cause than giving something good for the patient. Just a one word on the trap versus tube is always the choice is based on the IOP also. We have to see if the IOP is below 35 or even 40, the trap still works good in open angle glaucoma stage or even sometimes in the angle closure, because we know that in angle closure, even if you put a tube, especially it is going to touch the cornea many times. So we got to be really very careful when you're doing the tubes. It is not like child's play when you're doing the tube in a NVG. In experienced surgeons also, the tubes are not going to be very great in an NVG. But if the IOP is really high and your conjunctiva is very bad, I think one choice may be the tubes, but I always prefer to go for a trap as a first choice. But what is the real advantage in doing the trap is many people think it may fail, but it is not the truth because all these patients will require multiple anti-VEGFs. So the moment you give repeated anti-VEGFs, the survival of the trabeculectomy is much better in this case because I have quite a good number of NVGs where they've gone for multiple injections, especially those who are developed after the diabetic retinopathy. Those patients, they really do very well. So that is one practical tip I can give you. I'm sorry, I was in the other prayer meeting with Dr. Ravi Thomas's prayer meeting is ongoing now. So I was with the other meeting. Sorry about that.
Yes, I think we shall now go on to the last segment because we are very late. And the third masterclass is going to be delivered by Dr. George Manayat, who is a senior consultant retina and vitreous services from Darwin Eye Care Systems. I'm sure all of us know he's a extremely dynamic, prolific surgeon. And we have him here to talk on something so essential for this World Diabetic Day, management of diabetic macular edema, principles and practice. On to you, Dr. George. You have to keep it a little brief because I have not planned the meeting well. I mean, we're really running late. You have to unmute yourself. We don't hear you. We've not started yet, I think.
I think now I think I'm audible, isn't it? So,
yes.
And I hope my slides are visible. So,
yes.
Thank you for the opportunity, ma'am. And let's look at the evidence-based learning in DME management. So first we'll look at the evidence-based recommendations and look at few of the biomarkers which help guide the individualized treatment of DME. When we look for the level 1 evidence in DME management, it's obviously DRCR network, which is the world's largest clinical trial network, which has almost answered all the unanswered questions related to DME management. So the first learning point is that anti-VEGF injections with or without focal laser is the most effective treatment, and anti-VEGF agents improve vision over focal laser and even intravitreal steroids, though not all anti-VEGFs are equal. So when we look at the protocol I of DRCR, it has shown that anti-VEGF injection with focal laser deferred for the first 6 months have improvement in vision compared to focal laser or intravitreal triamcinolone steroid injection. And this visual gain is maintained over more than 5 years. And especially in the subgroup where the vision is less than 612 to start with, this improvement with anti-VEGF agents has been shown to be really prominent. So we look at the recommendation, it's an anti-VEGF with deferred focal laser for the first 6 months. But we have in practice, it is very common to combine anti-VEGF with focal laser. Yes, in protocol I also, they showed that 4 fewer injections and longer treatment-free intervals when we combine focal laser with anti-VEGF agents. So that is also a common practice, even we do it today. So now which anti-VEGF agent is the best? We have protocol T comparing head-on Eylea versus ranibizumab versus Avastin, and seen that especially in the subgroup where vision is less than 612 to start with, the visual improvement as well as the macular thickness reduction on OCT is better with Eylea than the other agents. And the recently concluded protocol AC of the DRCR net showed that if you start the treatment with Avastin and at 3rd month you switch to aflibercept, because of the suboptimal response with Avastin, still your vision is going to be at par with aflibercept started in the 1st month. And this has actually cost benefit implications when you start with a normal anti-VEGF and switch to a better potent anti-VEGF. So, and only thing is 70% of the patients started with Avastin had to be switched to Eylea during this 2-year study. That switch happened between first 3 to 6 months. And what is suboptimal response at 3 months of anti-VEGF therapy is if the vision has not improved by 5 letters, that is equivalent to 1 line, or if the macular thickness reduction is less than 10% after 2 anti-VEGF Avastin injections. So this is the something called early switch to aflibercept, especially in a situation of phakic clear lens. So the second learning point is that what is the best anti-VEGF protocol? It is the DRCR regime or DRCR protocol, because over time the need for anti-VEGF injections over the next years dramatically reduced with DRCR protocol. We know that monthly or 2 monthly fixed injections are not practical, so we have DRCR regime versus treat and extend regime. So what is DRCR regime is it has loading doses, not 3 loading in monthly injections, but it may be up to 5 monthly injections. And that is not only till the macula is dry, but further injections to maximize the vision and stop the injections. And then follow up the patient initially monthly and then extend it to once in 4 months follow-up. At any time, if there is a recurrence, PRN basis, the retreatment is initiated. So this is the DRCR protocol or DRCR regime. So first year, 8 injection, but second year you see that only 2 injection, third year 1 injection, and 4th and 5th year no injections were required. So this is the significance of early intensive treatment with DRCR protocol. Now coming to treat and extend regime, which is very popular in the West, they have 3 monthly loading doses and then extend the injections and reach up to once in 4 months injections. And then every 4 months the injection is given. Here it had 2 arms, treat and extend versus treat and extend plus Navilas guided focal laser in the second group. But the problem is both the groups, they had too many injections, around 18 injections had to be given. So that is a disadvantage when you compare to the DRCR protocol, where fewer number of injections and less treatment in the subsequent years. So the third learning point is that the many eyes with anti-VEGF therapy do not fully respond. Nearly 50% do not respond completely. And in this situation, the steroids come to help in reducing the macular edema, but not always improve vision. So when we look at protocol I and protocol T, it is seen that 40% of the ranibizumab eyes and 60% of the Avastin eyes had still persistent edema after the intensive 5 injections monthly that is given in this study. So here comes the role of steroids. wherein in chronic DME and recalcitrant DME, there is a multifactorial switch. The edema is not, vascular permeability is not maintained by VEGF alone, but there is a inflammatory cytokines and chemokines playing a role in the DME and vascular permeability. So the protocol you looked at this persistent edema cases, and they were switched to DEX implant versus monthly ranibizumab injections. So the macular edema in such persistent cases resolved well with DEX implant, and however the visual acuity was not significantly different from monthly injections of ranibizumab. However, in the pseudophakic arm, the visual gain was significant in the DEX implant group, and even the 15-letter gainers were much more in the DEX implant switch groups. So the American Academy, the expert consensus panel on recommendation in persistent DME despite anti-VEGF therapy. So they defined the persistent or recalcitrant DME after 3 to 4 monthly injections if the vision is less than 612, and if the macular edema reduction is less than 50% of the baseline, then you call it persistent DME, and their recommendation is to switch to DEX implant. So currently, as a first, the DEX implant is currently used as in recalcitrant DME, especially the pseudophakic eyes or eyes planned for cataract surgery. This was what I was referring to when you combine cataract surgery with a DEX implant. So the first, in some scenarios where recent cardiovascular, cerebrovascular events within 3 months or pregnancy and DME, prefer to give at first line DEX implant as the choice of treatment. And in some eye conditions like vitrectomized eyes, fibrous proliferation with the DME and subfoveal hard exudates, first line we might use, it might be advisable to use DEX implant or steroids as a first line. So the last learning point is that eyes with center involving DME and good vision, that is better than 6/9 vision, may be observed closely. Here in protocol V, aflibercept was compared to observation and focal laser when vision was better than 6/9 and they had center involving DME. It was found that the visual outcome as well as the macular thickness reduction was not different between aflibercept and observation over 2 years. So they may be observed, and it is important to note that 1/3 of the patients observed and 1/4 of the patients with focal laser required Eylea aflibercept injections during the 2-year study period on a PRN basis when the vision dropped to less than 6/9. So to summarize, the 6/9 or less than 6/9 vision with center involving DME, anti-VEGF injections with laser deferred for the first 6 months, and aflibercept is the better agent when the vision to start with is less than 612, and DRCR is the better protocol with early intensive treatment, reducing the further need of injections over the subsequent years. And focal laser is currently reserved at 6 months if it is persistent or with anti-VEGF therapy, or in a first line when there is a focal circinate maculopathy of diabetic macular edema. Patients with better than 6/9 vision, observation is sufficient, and anti-VEGF only if the vision drops to less than 6/9. And in recalcitrant DME, aflibercept in phakic eye switching and DEX implant switch in pseudophakics would be a good option. Having said that, these are the general guidelines based on the level 1 evidence that we discussed. So we have some predictors of treatment outcome in DME. To individualize the treatment, we have the non-invasive OCT angiographic biomarkers. I won't go into the detail, but there are important ones like the drill, hyperreflective foci, serous macular detachment, ellipsoid zone disruption, and ICHRM. These are guiding to individualize your treatment in DME. Now we have the OCT subtypes of DME like diffuse thickening, cystoid edema, serous macular detachment, or like this fractional DME. So these subtypes were looked whether these...
1 minute more.
Yeah, just give me a minute extra. So there is no consistent data to say that these morphological subtypes have any prognostic significance on outcome. However, it is agreed upon that gross cystoid edema with large outer nuclear cyst more than 200 microns has a poor bearing on visual outcome when you start treating these patients. And more importantly is the bridging retinal tissue that you see here, which is the residual neural elements of Muller cells that transmit the visual impulse from photoreceptors to ganglion cells. So this is a positive biomarker on OCT, which predict a good outcome when you treat these patients. Again, the serous macular detachment subtype on OCT suggests that the patient may be having associated systemic issues like renal problem, uncorrected anemia, uncontrolled hypertension. So this should draw your attention and needs a concomitant treatment of the systemic issue. And these hyperreflective foci less than 30 microns on OCT are actually precursors of subclinical hard exudate, which will cause a defective vision later on. So basically suggesting retinal inflammatory response, and corticosteroids may be better in multitude of hyperreflective foci than anti-VEGF. And drill or disorganization of the inner retinal layers, as you can see here, where the inner retinal layers cannot be delineated in the central 1 millimeter zone. If it is more than 50% of the central 1 millimeter zone, then you are looking at a patient where the visual outcome may not be good even with anti-VEGF injections. The ellipsoid zone disruption or ELM disruption, again a poor biomarker for treatment outcome in DME. And this ICHRM or intraretinal intracystic hyperreflective material, again a poor biomarker, which suggests of chronicity and suggests that these patients need multiple injections and lesser visual gain even with anti-VEGF therapy. So the OCT angiography lastly has this effaced enlargement of the deep capillary plexus. Still patient can have some improvement in vision. Later on, once the superficial plexus involves effaced enlargement and poor vessel density, capillary density, then you are looking at a patient whom the vision will not improve with improvement of injection of anti-VEGF. So this is the tool of choice, especially in pregnant and renal patient where dye-based angiography may be relatively contraindicated. So these biomarker, non-invasive biomarker, help guide treatment individualized to the patient. However, I conclude saying the foundation of DME treatment still remains good systemic control of hyperglycemia, hyperlipidemia, and hypertension. So thank you for your kind attention.
Thank you. Thank you so much, Dr. George. That was a very power-packed talk, and you said it all in your 10 minutes talk. We will go on to some discussion after the two debates. We have Dr. Koshal Ram, who's the medical director of the Ponnamal Doraisamy Eye Hospital and Retina Center. And again, a very popular figure in our CSO society. And he is going to talk on, with the evidence of newer DRCR protocol, is treatment of NPDR with pharmacotherapy warranted at this time? He would be talking for it, and against it would be taken care by Dr. Jayashree, who heads the medical retina services, heads the medical services at the Agarwal Eye Hospitals based at Coimbatore, and she is going to say no to this debate. So on to you, Dr. Koshal Ram.
Good evening, ma'am. Is my screen visible, everybody?
Yes.
Yeah. At the outset, I'd like to thank Chitra ma'am, Jayashree.
Make it full screen, sir.
Yeah.
It's not full screen yet.
Okay. Is it full screen now?
Not full screen. If you're having problem, you can go slide wise. I don't know.
So can I share your presentation?
Yeah, you can share.
Yes.
So good evening, everyone. At the outset, I would like to thank Chitra ma'am and CSOS. Next slide, please. So my talk today is going to be on, with evidence of newer DRCR protocol, treatment of NPDR with pharmacotherapy is warranted at this time. The answer is a firm yes. Next slide. So we are aware of the definition of CSME from our PG days. So categorized as retinal thickening happening within or just adjacent to the fovea along with the hard exudates. With the advent of OCT, we categorize DME as a center-involved DME if the cystoid spaces are located in the center of the fovea. Next. Or a non-center or a paracentral DME in which the DME component happens outside. Next. NPDR has its presentation as mild, moderate, and severe as defined by the ETDRS and the 4-to-1 rule, all of which has some form of DME at presentation. Next slide. So the pharmacotherapy should be individualized. At the bottom right corner, you have got a DME which is mild with a few Hardick states. On the upper top, you have got a DME with more extensive Hardick states. And the left lower part, you have got extensive Hardick states. So you have to individualize treatment for each and every patient. Next. So the pharmacological treatment should be initiated at the earliest and continued for a period of time. Next slide. Next slide. The pathophysiology of NPDR, we know inflammation is the key factor along with production of VEGF. Next slide. We've got multiple pathways, the protein kinase C, the VEGF, the formation of AGE products, all contributing to that. Next slide. So as George mentioned in elaborate, we've got the RISE and RIDE trials for ranibizumab, we've got the BOLD for bevacizumab, you've got the VISTA and VIVID trials for aflibercept, and you've got triamcinolone and the DEX implant. Next slide. So the VEGF levels are increased proportionately in these eyes, and inhibiting VEGF is the most useful therapeutic modality. Next slide. So the DRCR, a quick recap, it actually evaluated the standard of care laser with the ranibizumab with the prompt and deferred laser. Next slide. Next. So next slide. The ranibizumab with the prompt and deferred laser did very well with the primary endpoint at 1 year. And this is something is important. With the subgroup analysis of the worsening of retinopathy, in which they said that the ranibizumab with prompt laser, nearly 25% of the eyes had a 2-level improvement in retinopathy in moderate or severe NPDR or better. And cases of severe NPDR or worse, there was a 28% improvement in retinopathy. Next. These are not my images. They are taken from the DRCR. And this is a patient who has undergone 9 monthly injections of ranibizumab. You can see that the severity of NPDR and DME has been considerably reduced. Next slide. Next slide. So this is important. So the pharmacotherapy, how long, when to switch, and when do we call a non-responder? As George clearly told, we give a loading dose of 3 injections and wait for the response, which can be even a 10% reduction in the central retinal thickness. And then if there is a response, you consider administering another 2 to 3 injections totally. So you give a total of 6 injections, and then you categorize and treat them on a treat and extend protocol or a PRN. Subsequently, if there is no response after 6 injections, you consider them as a non-responder, and that is the period when you have to switch over to other forms of therapy or a steroid. Next. So next, real-time scenario, we see cases like, next slide, a situation where, next slide. Okay. A case of a severe NPDR with a DME at presentation, next slide, with a serous detachment in OCT, a vision of 624, next slide. This patient undergoing 5 monthly injections of ranibizumab, having a considerable reduction in thickness, and this after 9 injections. After 9 injections over a period of 2 years, you can see that the retinopathy profile is better. This is another scenario, pseudophakic, having a DME, a vision of 624, next slide. This patient undergoes an Ozurdex implant with reduction in macular edema, sustained the implant fractures, but still there is a response. The response maintained towards 5th month, then I guess there is a rebound, and then again for another Ozurdex implant. Next. So the question, as George clearly showed, which anti-VEGF is better, Avastin, ranibizumab, aflibercept? The protocol T said that having a visual acuity of 6 by 12 or worse, then the aflibercept is better. Next. Next. The protocol T categorized all the 3 drugs and then said if patients with poor vision of 612 or worse, aflibercept was better. Next. So the key points. Anti-VEGF is very effective, but you have to treat appropriately and ideally, yes. And it's fast acting. You have to give a minimum of 6 injections and wait for response. Don't treat less and then wait for response, because it targets VEGF and the inflammatory cascade as well. The rebound or resistant cases have to be properly identified and treated. Caution to be exercised in cardiovascular disease and stroke. If there is a patient having scenic probably we can switch over them to probably an Ozurdex, which will give a response and then resume the treatment. Next. My talk will be incomplete if I don't talk about systemic control of blood sugar, hypertension, hyperlipidemia. Very important when we are doing these injections. Next slide. Next slide. So laser has got its drawbacks. My colleague Dr. Jayashree will be talking about laser. We all know laser causes collateral damage in macular edema, and laser scars treated years later are difficult. So at present scenario, the treatment is injection, injection, and injection. So we have to follow the treatment protocol in case of an NPDR with DME. Next slide. So pharmacological treatment is the gold standard for treatment of NPDR DME. Frequent injection till the disease stabilization will be the norm in the future. Thank you. Next slide. Thank you all.
Thank you. Thank you, Goshal. That was a wonderful talk. So let's hear from Jayashree what she has to contest against this. Dr. Jayashree?
Yes, ma'am. I'll share my screen.
Jayashree, following this, you can take one question before we go to the last set of debate because we are running very late.
Is my screen visible now?
Yes. You have to
make
go
it
to slideshow.
Yes, going. Fine?
Yes, fine.
At the outset, I would like to thank Chitra ma'am for giving me this opportunity. And I think somehow this debate has got a little messed up because so I think we have misunderstood the topic. I totally agree with Koshal because pharmacotherapy is warranted for DME. And I was under the impression that the topic is pharmacotherapy only for non-proliferative diabetic retinopathy. Not for DME, because all of us know that DME, of course, we need intravitreal injections, and laser is can be done along with it, but primary treatment as of now remains intravitreal injection. So I have prepared as intravitreal injections for NPDR, for non-proliferative diabetic retinopathy, and I would say a no for that, because I thought that is the latest thing that is going on now, and I thought we had to talk about this.
Yeah.
So, what do we know about diabetic retinopathy till date? We know we have got diabetic retinopathy treatment guidelines, and these remain predominantly reactive, which means that we treat only when there is some vision-threatening complication, that is, when there is a center involving DME or a PDR develops. So, we have our age-old studies, the diabetic retinopathy study, which showed us that photocoagulation reduced the 2-year incidence by more than half in eyes with PDR, high-risk PDR as well as early PDR. But in NPDR, the risk reduction was only from 3.2% to 2.8%. And also the ETDRS study, which showed us that photocoagulation is not recommended for eyes with mild to moderate non-proliferative diabetic retinopathy. And it is only when retinopathy is more severe and has reached the proliferative stage that we have to treat it. So why are we revisiting this problem now? This is because ETDR was a very good quality and detailed study, but this was conducted several decades ago. And the one question that remains now is, because there have been a lot of new developments, has the application of ETDRS changed? So what are these new developments? So we have improvements in the diabetes care of BP and lipids. There are changes in the laser delivery systems, advances in laser technology, advent of new drugs for diabetic maculopathy and PDR, and advances in imaging such as OCT. So how did these recommendations that NPDR has to be treated start? This was because of the ad hoc analysis of the RIDE and RISE and RISE and RIDE and VIVID DME and VISTA DME studies, which basically showed that in patients who had diabetic macular edema, when anti-VEGF injections were given, the diabetic retinopathy severity scale reduced by a minimum of 2 steps. So then there were primary studies to evaluate whether it would work in NPDR alone without any diabetic macular edema. So an important study was the Panorama, which showed that at the end of 2 years, almost 50% of the which showed no visual benefit with intravitreal aflibercept in the early NPDR stages in moderate to severe NPDR as compared to performing observation in these cases and injecting only when they progress to PDR or DME. And so then we have these studies which are telling us to give injection to patients who have non-proliferative diabetic retinopathy. So what are the scientific reasons not to inject these patients? All these studies which showed us that there was an improvement in the diabetic retinopathy severity scale did not show us that this is associated with a better retinal perfusion or a retinal reperfusion. And it is not apparent whether this improvement is actually a disease modification or just a temporary benefit that the patients had. And in both these studies, there was no significant visual improvement whatsoever noted in the group that was treated with intravitreal anti-VEGF injections versus the untreated group. Now, let us come to the practical difficulties of injecting these patients. We know that most of these patients without any diabetic macular edema will have a typically good vision, and it is not easy to motivate these patients who do not have any symptoms to start injections. And they will be anxious about starting injections because they are convinced that they are absolutely normal and they do not have any active disease. Other than this, the treatment burden is one important factor that we have to consider. The cost, the repeated visits to the doctor, all this adds on to whatever other medical interactions these patients are having because of diabetes and the other comorbid conditions they are experiencing. The number of injections required in these patients is still unclear, and it is not clear how durable this approach is. That is, whether it will actually improve the quality of life of our patients. The limitation of long-term outcomes related to the current data and the risk of giving multiple intravitreal injections in patients who are having good vision. Last but not the least would be, of course, the cost factor which the patients have to undergo. Another thing that we have to think about is how to determine response to injections in these patients with NPDR, because in PDR we can see the new vessels regressing, and in DME we can see the has reduced, but in NPDR it is a little more challenging, and we do not have verified endpoints to monitor the response to this treatment. We need more validated endpoints and has to be managed. Other than this, as Jotzer's presentation clearly put forth, DR is a multifactorial condition. Diabetic retinopathy is not synonymous with just one chemical mediator or just with VEGF or just with inflammatory mediators. So we do not know what it is in the patients, but in that particular patient that is causing the condition. Protocol I study was the graph was shown by Jotzer. Only 40% of the patients gained very good vision. Another 30% gained only 6 letters, and almost 30% did not experience any significant visual improvement. So all this shows that there are multiple mechanisms involved, and we do not know what it is in a particular patient that is causing the diabetic retinopathy changes, and we cannot blindly go and treat them with either anti-VEGF or with steroids. In DME, we have multiple studies which show us what is the response that is expected, what is suboptimal response, what is a non-responding DME, and how we have to go about it. But all these are not known in an NPDR patient. And the most important question still remains about the patient's adherence. Just to start a patient on treatment obligates that individual to routine monitoring, follow-up, and continued intravitreal injections. And in a country where we are still discussing about how to improve our follow-ups for patients with vision-threatening problems like AMD, DME, CRVOs who need monthly injections, and these patients we are not able to call for follow-up and give them injections. So I feel that in a country like ours, it would be next to impossible to treat an NPDR patient with intravitreal injections. So to summarize, we are only left with active monitoring as far as the eye goes as the preferred option for the majority of NPDR patients, because the active treatment options, there are so many unanswered questions. We have to only focus on the systemic control and sensitize the patient to better control of the diabetes, hypertension, and the lipids. And while watchful waiting is the paradigm, there are some key learnings that we have got about the history of severe NPDR from the Panorama study. And this is that in the Panorama study also, it was just 50%, it was still 50% of the eyes which developed vision-threatening complications by 100 weeks. And this closely replicates findings from ETDRS studies that were performed almost 3 decades ago. So it just shows us one thing, that in spite of all the better systemic medical therapies available for diabetes, somehow the rate of progression from severe NPDR to PDR with vision-threatening complications has not improved. Our patients have got the same risk even now, and which means that NPDR cannot be taken lightly and has to be monitored very rigorously. Thank you.
Thank you. That was a wonderful talk, Jayashree. Would you want to take just one question for this group of talk? Because we have one next chunk, the debates, the fourth section left. Would you take one question for the early three speakers?
Yes, shall we complete the others one also? That is also diabetic macular edema.
Okay. So we shall now go on to the fourth debate, which is going to be taken up by Dr. Tenarson, who's a vitreoretina surgeon from the Eye Foundation Group of Hospitals, Coimbatore. Again, a very dynamic surgeon. And he is going to tell us, can biomarkers be used to determine if steroid versus anti-VEGF agent are more appropriate to treat DME? And he's going to talk for the debate. And against the debate would be dealt by Dr. Ashish Sharma, who's again a senior vitreoretina consultant from the Lotus Eye Hospital. And we will look forward to this very interesting debate. On to you, Dr. Tenarson.
Good evening, ma'am, and thank you for this wonderful opportunity. My slides are visible, ma'am?
Yes.
Yeah, so I'll be talking for OCT biomarkers and DME, which is favoring in for anti-VEGF. So as we all know, the pathogenesis of diabetic macular edema is mainly due to the increased VEGF, which in turn causes the breakdown of inner blood retinal barrier. And so why should we prefer anti-VEGF over steroids? So to understand this, we should see the following OCT biomarkers. So if you look at the intraretinal cystoid spaces, these are small cystoid spaces which could be present either in inner or outer retinal layers. So they could be categorized either as small, large, or giant depending upon their size. So the studies have shown that anti-VEGF therapy has showed very good decrease in number and sizes of the outer nuclear retinal layer cyst, thereby decreasing their pathology. And the next is the subfoveal neurosensory detachment. The prevalence is almost 15 to 30% in DME. So in RESTORE and post-track analysis of RISE and RISE study, the presence of subretinal neurosensory detachment has shown some protective role. So at the end of 1 year, if you look at the presence of baseline subretinal fluid, there's a better visual gains are noted. And definitely the positive impact is noted post ranibizumab therapy. So this is a small new entity, which is subfoveal choroidal thickness. So if you look at this, the patients who had a greater baseline choroidal thickness will respond better to the anti-VEGF therapy. And this is due to the protective nature to the photoreceptor and RPE as well. And if you look at the central macular retinal thickness, which is a non-specific marker, which could respond both to the anti-VEGF and steroids as well, but this is a non-specific marker. So not necessarily that the central macular thickness reduction should correspond to the visual gain. So this is, as Jaj sir has told, this represents a good visual prognosis. It's a bridging retinal process. It connects the outer and inner retina through the Muller cells. Their presence indicates a good prognosis. And drill, which is disorganization of retinal inner layers, their presence more than 50% of the central 1 millimeter retinal zone, which signifies worse visual prognosis, and it acts as a good biomarker for the visual acuity, even in the presence of diabetic, even in the absence of diabetic macular edema as well. So these are all hyperreflective retinal foci. These are nothing but subclinical riboproteins that extravasate after the breakdown of inner retinal barrier. So they do respond both to the anti-VEGF and steroids, but more in favor of steroids. So it signifies the retinal. Similarly, hyperreflective choroidal foci is nothing else but a migration of these foci from the retinal into the choroidal layers. Their presence is significantly more in PDR cases than NPDR cases. And these are all hard exudates. And again, these are a lipoproteinaceous material which accumulates due to the breakdown of inner blood retinal barrier. And their response will be both good for anti-VEGF and steroids, but more in favor of steroids. The integrity of external limiting membrane and ellipsoid zone is very important for the good visual acuity. Their presence always helps in protecting the RPE and underlying photoreceptors. And last but not the least, the tractional component, if it is there, it is always responsible for the recalcitrant macular edema. So it will not usually respond both to the anti-VEGF and steroids. The surgical indication is always necessary. To summarize with the OCT biomarkers, anti-GF has an upper hand in cases of intraretinal cystoid spaces, subfoveal neurosensory detachment, and subfoveal choroidal thickness, whereas steroids has an upper hand in cases of hyperreflective retinal foci, hard exudates, hyperreflective choroidal, equivocal in cases of drill, integrity of ELM, and bridging retinal process. But considering this, why would I consider anti-VEGF? In protocol I, if you look at the ranibizumab group and steroid with prompt laser group, at the end of 1 year, the 4-letter visual gain, there is no significance between both the groups. And in the protocol U, if you see the anti-VEGF versus anti-VEGF plus steroid group, there is no significant difference at the end of 6 months in terms of visual acuity, but definitely there is an IOP rise in the combination group. So coming to the side effects of steroids, ocular hypertension, definitely with a single dose injection, if you look at the tabular column, the percentage of ocular IOP rise is very, very high. Whereas in cases of anti-VEGF, the percentage of rise is very less, especially it is noted only in those cases of multiple injections. So cataract surgery and IOP rise is a costly sequelae to the intravitreal steroids. And if you look at this picture, Osudas implant can migrate into AC, even IVTA can migrate into AC, especially in those cases of PCR, and it can cause increase in floaters to the patient as well. So to summarize the efficacy of the two drugs, if you compare all these multiple studies, if you look at the baseline to at the end, the anti-VEGF has better role, and we have other new group of drugs as well. For example, brolucizumab, which is being studied in Kestrel and Kite DME trials, they have a good impact in subfield clinical thickness as well as compared to the aflibercept. Whereas the recent Bolivar trial, the upcoming drug faricimab, has a better impact compared to the ranibizumab group. So I would consider anti-VEGF in cases of steroid responder, and in cases of tachyphylaxis, I can shift to another group of anti-VEGF drug. So my first choice would always be anti-VEGF, second choice and third choice would always be anti-VEGF. Only in cases of chronic recalcitrant edema and pseudophakic edema, and those cases which have hard exudates and hyperreflective retinal foci, I would consider steroids. Thank you.
Thank you. Thank you very much, Thanarsan. That was a good talk. So on to you, Dr. Ashish.
Put my slides up. Okay, can you, am I audible and visible both?
Yes.
Okay, so thank you, Dr. Chitra, for giving me wonderful opportunity, and it's late night, so I will not keep you away from your dinner. I'll be very quick because a lot of work has been already done by George and
make it full screen, sir.
Sorry, sir?
Full screen. Slideshow.
Slideshow. Okay. Yes, got it. It's good now?
Yeah.
Okay. So Thanarsan, I am completely, I agree with you that, anti-VEGF is something that we should use primarily for diabetic macular edema. But I think the topic of our debate, means our, tussle, was that whether biomarkers can predict that what kind of choice that you should have. So that is what I'm going to talk about, that why biomarkers have a major role in choosing steroids. Means I have complete agreement that overall anti-VEGF your choice for DME, but not on the basis of biomarkers. Let me explain you in few slides. Before I proceed further, these are my disclosures. So George has nicely explained that, what kind of biomarkers that we usually encounter in our day-to-day practice, and they predict prognosis, they help us in management decisions. A lot of biomarkers are research tool. Drill we have talked about. We have talked about hyperreflective foci, which is a predictor of exudation and intraretinal cysts. I mean, I'm not going to detail because everything is being talked about. Subfoveal neurosensory detachment, which is again, guide us, what kind of treatment we should do. Bridging process, George nicely said, it has a good prognosis. Once it's lost, bad prognosis. Now the question arises, do I need to use them in something? Do they make sense to me? That how should I treat my patient? Means whether I should choose an anti-VEGF or I should an steroid. So if you really look at the biomarkers, there is no way you can choose anti-VEGF based on the biomarkers, because anti-VEGF can be used in any condition. But if you really want to use your biomarkers to choose a drug, that is a steroid. Because biomarkers, they give you some kind of sense that this is an inflammatory process. So there are some biomarkers which are more inclined for inflammation, and that's where it guides you that you should use steroids. Anti-VEGF can be used anywhere, so they usually do not guide at all that you should anti-VEGF. So there is enough literature to support this. For example, if you have hyperreflective foci, subretinal neurosensory detachment, that means it's a sign of inflammation. So, even after using anti-VEGF, these are not responding, that is better that you use steroid as a treatment of choice. Steroid always gives you a better anatomical result. Even this was our own paper where we compared both of them, and steroid was definitely giving better anatomy, as George also quoted one of the phase 3 trial. So a lot of markers means, again, this is reiteration, subfoveal neurosensory detachment, and apart from that, hyperreflective foci. Means these are few important biomarkers that we encounter in our day-to-day practice. Even DRL extension, CMT, cyst areas, DCP, all these are inflammatory signs. So ultimately, the guidance comes from these biomarkers that yes, these are the inflammatory signs, and you should use a steroid as agent. And this is our paper where we have find algorithm that how you should treat in a minimized way of treatment, whether it's anti-VEGF or steroid. But if you really look at the picture of the OCT, this is probably a patient which you can treat with a steroid. If you look at the top scan, it has hyperreflective foci, it has neurosensory detachment. So all these are inflammatory biomarkers. So if you really talk about one sentence that biomarkers, do they help? Definitely not to the anti-VEGF, just for the steroid as far as indications are concerned. So I have summarized everything in 2 minutes, so that everybody can go for dinner on time. Thank you so much.
Thank you, Dr. Ashish. Jayashree, are you there? Dr. Jayashree?
Yes, ma'am. Yes.
So could you take 1 or 2 very relevant questions, and we close the wonderful webinar we've had today.
Oh, George, one question.
Yeah,
Yes.
Yeah.
Yes, sir, George, sir.
One question.
Yeah, please.
No, that actually the protocol has told inferiority of PRP. Monthly ranibizumab demonstrated inferiority of PRP, and in that protocol has had 19% cases of severe NPDR.
Yeah, Kaushal, I would like to comment on that actually, because the protocol S, actually, there was a drive to use anti-VEGF for PDR instead of PRP laser. And when the 5-year results came after this protocol S, the 5-year results came, it is shown that anti-VEGF as a standalone treatment for PDR doesn't work. 1/3 of the patients were lost to follow-up after 5 years, and 1/3 of them developed neovascular glaucoma, which was discussed by Dr. Satyan and very well discussed here. So as a standalone treatment, and even it was not even non-inferior to PRP. Actually, if you look at the 5-year results, PRP is still the gold standard for PDR. So in this context, the first debate which Jayashree had mentioned, when you look at not DME and only NPDR, even the recently concluded protocol W, which has come out, showed that there is no benefit, though there is a transient decrease in the diabetic retinopathy severity scale with anti-VEGF. That is not a long-lasting thing. And at the end of 2 years, there was no difference between people who received anti-VEGF in severe NPDR I am talking about. So patients who had anti-VEGF and patients who did not had anti-VEGF. So I do not think that that is a viable option. Even if it's a ideal patient who comes for treatment, I think it is not recommended to, at this point of time, I do not think anti-VEGF is an answer for severe NPDR.
Judge, anything up to Z you have?
Pardon me?
From A to Z, you have all the studies. You have mentioned T, S, V.
The last two which of interest to this group, retina group, are protocol W and protocol AC, which just came out few months back. So I think that is the reason why Madam has included this debate topic also, because the protocol W is very new to this addition. Because in West, people tend to use anti-VEGF even for NPDR. That was the reason why they did a study like that to answer, whether it is any use or not. It is not really useful, I think.
We only understand last 3 words, which is GVP. All other words we don't understand.
Protocol AA is
Just to
also
be on
available.
the joker side, earlier days we used to say in glaucoma, we had only 2 drugs, timolol and pilocarpine. Now you people have only these 2 drugs, either anti-VEGF or steroids. So you are still in the primitive phase to treat the diabetic retinopathy than what we have, progressed to.
But we have superb anti-VEGF in the pipeline.
So I think great discussions on diabetic retinopathy. Anything else anyone would like to add?
No, I think we should call it a day. We've run half an hour, 40 minutes late. But I think it has been an amazing webinar. Every single speaker was so passionate and so eloquent about the talk. And I think all of us on the expert panel, or the speakers, or the moderators, we had so much to learn, because there's just unimaginable flood of information and learning and clarity of thought process about each and everything which was discussed. So 3 cheers to CSOS for this wonderful program, which happened only because of each of you speakers. And I'm sure many of them who have been watching you all today are going to feel the same, that they have learned so much today, because right from cataract to glaucoma to retina, every topic was very relevant. And I need to specially thank Ashray in this, because, I asked Ashray, can you help me put together the topics for this webinar? Because I felt we have to deliver the best to CSOS. And I'm sure even when he put the topics together, he never visualized that this is going to be the final outcome. So 3 cheers to all of you. Thank you so much, expert panel. Thank you so much, speakers. Thank you.
Ma'am, just wanted to add one final. So though all these 3 specialties were combined, for the patient we have to have a all the 3 specialties have to work together. So that is when we can prevent NVG, can manage these outcomes better. So all the 3 specialties have to work in unison to get better visual outcomes for our.
Thank you. Good night, everyone.
Thank you, madam. Thank you. Good night.
Thank you, madam. Thank you. Thank you, everyone.
Thank you.
Chitra madam, just Chitra madam, switched off.
No, you're audible. Satyan sir, go ahead.
I just wanted Chitra madam to announce for the next meeting, that is on the